For the retrograde femoral nailing is intended for use in intramedullary fixation of fractures of the femur to include the following: supracondylar fractures, including those with severe comminution and intra-articular extension, open and closed distal femoral fractures, pseudoarthrosis in correction of osteotomy, pathologic fractures or impending pathologic fractures and tumor resection, bone lengthening, fractures distal to a total hip prosthesis, non-unions and malunions, fractures resulting from osteoporosis. For a retrograde approach, the patient should be positioned in a supine position on a radiolocin table with the injured leg draped free and a bumped under the ipsilateral hip. The C-arm should be positioned to allow imaging of the femur in both planes along the entire length of the bone. Place the knee of a sterile bolster to maintain approximately 30 degrees of flexion. Use manual distraction or a femoral distractor to reduce severely displaced fracture and to restore length. These are the following instruments needed for femur intramedullary nailing. First is the bone major set, power tool set, intramedullary nail sets from the company, intramedullary reamer sets, femoral distractors, olive tip guide wire, and entry guide wire 3.2 mm. The entry point of the nail is located in line with the femoral canal on the AP view and just anterior to where Blumensaat's line intersects the anterior intercondylar notch on the lateral view. Assemble the 3.2 mm pin guide into the soft tissue protector and place it through the incision. Align the soft tissue protector with the femoral shaft on the AP and lateral image view and insert a 3.2 mm guide pin. Place the 13.5 mm cannulated entry reamer over the guide pin and ream the distal femur through the soft tissue protector. The grooves on the entry reamer in relation to the soft tissue sleeve represents how far the nail can be countersink at 0 mm, 5 mm, and 10 mm. Alternatively, the surgeon may open the entry point with a cannulated curved awl followed by a 3.0 mm ball nose guide wire that is placed over the curved awl to the desired depth. Remove the awl and introduce the 13.5 mm cannulated entry reamer over the 3.0 mm ball nose guide wire. Remove the entry guide wire and introduce the 3.0 mm ball nose guide wire by means of the guide wire gripper past the level of the fracture to assist in fracture reduction, and a curve reduction tool and handle may be used. Then determine the proper nail length by sliding the guide wire depth gauge over the guide wire to the level of the intercondylar notch cortex. Read the appropriate length directly from the each line on the ball nose guide wire. Then begin reaming with the 8.0 mm end cutting reamer. Progressively ream until cortical chatter is achieved. Ream 1.0 mm to 1.5 mm over the desired nail diameter. Then for nail assembly, attach the retrograde radiolocin targeting guide to the nail using the connection bolt, T-handle, and ball hex driver. If using oblique screws, the retrograde targeting guide arch should be attached to the main body. After the nail assembly, introduce the nail into the femur using the retrograde radiolocin targeting guide in a rotating motion to allow easy insertion according to femur curvature anatomy, and pass the nail over the guide wire. If the nail does not enter the femur easily, use a mallet to apply a gentle blow to the impactor pad. It is very important to never hit directly on the radiolocin targeting guide. Then remove the ball nose guide wire. Then make a small incision and insert the sheath, drill guide, and obturator laterally until it contacts the cortex of the femur. When desired orientation is achieved, remove the obturator and drill with a calibrated 5.5 mm drill bit. The length of the screw can be read off the guide. Drill both cortices in the desired transverse location. Note the calibration for the screw length when the drill has just reached the far cortex. Do not remove the drill. Then assemble the condylar nut, Hicks driver, and condyle locking collet. A washer must be added to the condyle nut on the inside of the retrograde nail jig. The condylar nut can be captured by the Hicks driver. The distal aspect of the condylar nut has teeth and is self-drilling. Drive the condylar nut through the femoral cortex. The condylar nut will go over the previously placed 5.5 mm drill bit. Turn the condyle locking collet clockwise, and to it is snug, keeping the 5.0 mm hex driver engaged with the condylar nut. Remove the drill bit and select a screw that is 5.0 mm, shorter than the measured length. Insert the 6.5 mm cortical or cancellous screw. Add a washer to the screw on the inside of the jig as it exists in the sheath. The screw will follow the drill path and thread into the condylar nut on the opposite cortex. Apply compression across the fracture until the washer on each side of the femoral condyles are flush with the bone. An additional proximal locking screw near to the supracondyle is applied. For additional nail stability, the interlocking screws is recommended. For interlocking screws, apply the drill sleeve to the radiolocent targeting guide armhole for interlocking screw. Then drill using the 4.0 mm calibrated drill through the first cortex. When hitting the second cortex, stop and measure and call out for the length. Then, finish second cortex. Remove inner sleeve and insert the screw using 5.0 mm hexagonal drive. Using a perfect circle technique, drill bicortically in the proximal femur with a 4 mm drill bit. Fluoroscopy can be used to assist. Screw length can be measured from the green line on the 4 mm drill bit reference of the proximal depth gauge slit. Alternatively, a standard depth gauge can be used.